Hello and welcome to today's lecture on hypertension. This is the first part of a two-part series where we will be discussing the classification, the etiology, and the clinical evaluation of hypertension. I am Dr. Kelvin, a consultant physician. Let's dive right into this very important and high-yield topic. By the end of this session, you should be able to clearly define what hypertension is, classify hypertension using key international guidelines, distinguish between primary and secondary hypertension, and finally, describe how to clinically evaluate a patient with hypertension, covering the history taking, physical examination, and investigation. Let's now begin by understanding the basics. Hypertension is one of the most common medical conditions globally. It affects nearly 1 in 3 adults and is often called the silent killer because it is asymptomatic. It significantly increases the risk of heart disease, stroke, kidney failure, and even premature death. Factors like aging, obesity, and unhealthy lifestyles are driving its rising prevalence. Early detection and aggressive control of blood pressure are crucial in reducing disease burden and saving lives. So, what is hypertension? Simply put, it is a persistent elevation of arterial blood pressure. Different guidelines have their own diagnostic threshold. For example, the JNC7 uses a threshold of 140/90 as definition of hypertension. The ESH also uses 140/90 millimeters of mercury. However, the American College of Cardiology uses a lower threshold of 130/80 millimeters of mercury. The NICE guideline uses a threshold of 140/90 as clinic blood pressure. However, this has to be confirmed using the ambulatory blood pressure measurements or the home BP monitoring. Confirmation threshold for this is 135/85 millimeters of mercury. So this is the JNC blood pressure classification, which classifies blood pressure into 4 stages: normal BP, pre-hypertension, stage 1 hypertension, and stage 2 hypertension. Like we said, the threshold using the JNC guideline is 140/90. However, JNC introduced the stage before hypertension called the pre-hypertension, which is defined as systolic blood pressure of 120/139 or a diastolic blood pressure of 80/89. It is important to state that pre-hypertension is like a warning zone before the full-blown hypertension develops. It is a risk state and not true hypertension. Confirmation actually requires readings on 2 to 3 separate visits. It is strongly associated with future cardiovascular events, and management is non-pharmacological, basically lifestyle modifications like salt restriction, physical activity, weight loss, and dietary adjustment. However, if the patient has diabetes or chronic kidney disease, drug therapy may be indicated earlier. This is the American Heart Association and American College of Cardiology blood pressure classification. This guideline made a bold move by redefining hypertension at a lower threshold of 130/80. The classification includes normal, elevated, stage 1 and 2, and the hypertensive crisis. The goal of this change was to promote earlier intervention, especially in people at high cardiovascular risk. So more people will now be labeled as hypertensive, but it means we can start managing them earlier to prevent complications. This guideline kept 140/90 threshold as hypertension. The difference now is that it introduced more categories for better risk stratification. There is optimal, normal, and high normal, while hypertension starts from 140/90 and above. It also defined the isolated systolic hypertension as systolic blood pressure greater or equal to 140 and diastolic blood pressure less than 90. The good thing about this classification is that this breakdown allows clinicians to tailor their interventions more precisely, deciding when to begin with lifestyle advice and when to initiate medications. This is the nice guideline for classification of hypertension. This guideline actually follows a more practical approach. It defines clinic hypertension as a blood pressure of 140/90 and above. But here is the key point. This must be confirmed using ambulatory or home blood pressure monitoring. In other words, a diagnosis is made if either of those two methods, that is the ambulatory or the home BP monitoring, shows a mean of 135/80 or more. This helps to reduce both false positives, as like in white coat hypertension, and false negatives like in masked hypertension. Before we go further, let us look at some key terms in hypertension. The first one we'll be looking at is the isolated systolic hypertension. This is when we have the systolic blood pressure greater or equal to 140 with a diastolic blood pressure less than 90 millimeters of mercury. This is common in the elderly, especially due to arterial stiffening. Then the white coat hypertension. This is when an individual has a high BP in the clinic and normal BP outside the clinic, perhaps at home. This usually is caused by anxiety during clinical visits. Confirmation of the diagnosis is also through ambulatory or home BP monitoring. We have the masked hypertension. This is when we have normal blood pressure in the clinic and a high blood pressure at home. Missed diagnosis, like will always delay treatment. Delay by hypertension. This is intermittent elevated blood pressure, often related to emotion or stress. These various types of hypertension, they are associated with increased cardiovascular risks if they are undetected or unmanaged. Let us look at the epidemiology of hypertension. Hypertension is the leading cause of premature death globally. Currently, about 30 to 45% of adults are affected, and the numbers are rising in low and middle income countries. Why is this? Reasons include urbanization, sedentary lifestyles, poor diets, and limited access to healthcare. Another important fact includes that the risk of cardiovascular event doubles with every 20 millimeters of mercury rise in systolic blood pressure or 10 millimeters of mercury rise in diastolic blood pressure, starting from a baseline of 115/75 millimeters of mercury. Hypertension is closely linked with stroke, kidney disease, heart attacks, and early deaths. This underscores the need for prevention, early diagnosis, and consistent follow-up. It's important to know that blood pressure patterns varies with age. Systolic blood pressure rises continuously as we get older. However, diastolic blood pressure usually increases until around the age of 50 and then starts to decline. Here is the clinical implication of this. In people under 50 years, diastolic blood pressure is a better indicator of cardiovascular risk factors, while in those over 50, systolic blood pressure becomes more important. This shift explains why isolated systolic hypertension is common and dangerous, especially in the elderly. It carries a high risk of stroke and heart disease and should not be ignored or undertreated. Now we'll look at the risk factors for hypertension. It can be divided into non-modifiable and modifiable. For the modifiable risk factors, we have age. The risk of hypertension rises significantly after 55 years. Next is family history. This plays a strong role in the development of hypertension. It is said that first-degree relatives with hypertension increases your risk of developing hypertension. Next is gender. Gender matters too. Men are more likely to develop hypertension earlier in life. However, women will definitely catch up after menopause. Next is ethnicity. This is very critical. People of African or Afro-Caribbean descent tend to have higher prevalences, more severe disease, and earlier complications. Low birth weight or premature birth. This has been linked to smaller number of nephrons, which may predispose individuals to hypertension later in life. Now let us take a look at the modifiable risk factors. These risk factors are actually the focus of prevention. Obesity and overweight. They've been strongly linked to high blood pressure. Physical inactivity and a sedentary lifestyle. High salt intake, especially in processed food, are major drivers. On the other hand, low potassium intake worsens the problem. Excessive alcohol consumption, smoking, and unhealthy diet have also played roles. Other medical conditions like type 2 diabetes mellitus, dyslipidemia, obstructive sleep apnea also increase the risk of hypertension. Finally, chronic stress and poor sleep both have been implicated in hypertension risk. These are the areas where lifestyle modifications can make a real difference, both for prevention and treatment. Let us look at the types of hypertension. There are majorly two types of hypertension, the primary and the secondary hypertension. We'll start with the primary hypertension, also called the essential hypertension. It accounts for about 90 to 95% of all hypertension cases. And here is what you need to know. There is no single identifiable cause. The condition develops gradually over time, and the pathogenesis is multifactorial, involving genetic, environmental, and lifestyle factors. Because it has no specific cause, management focuses on controlling blood pressure and reducing long-term complications. We'll be looking at the mechanism of primary hypertension subsequently. The pathogenesis of primary hypertension is multifactorial, involving genetic predisposition, where we have many genes actually influence sodium handling, as well as vascular tone and responsiveness to stimuli. Sympathetic overactivities, higher levels of norepinephrine can lead to increased heart rate as well as vasoconstriction. The renin-angiotensin-aldosterone system helps to promote sodium retention and vasoconstriction. Endothelial dysfunction. This results in reduced nitric oxide availability and impaired vasodilation. Insulin resistance, which is common in metabolic syndrome, causes sodium retention and vascular smooth muscle hypertrophy. Then finally, the reduced nephron number, particularly in people born with a low birth weight. This limits the kidney's ability to handle sodium, predisposing to hypertension. All these contribute to the gradual rise in blood pressure seen in primary hypertension. Now let us turn to secondary hypertension, also referred to as non-essential hypertension. It accounts for about 5 to 10% of hypertension cases. Unlike primary hypertension, secondary hypertension has an identifiable and often reversible cause. You should suspect it in the following situations. 1. New onset hypertension before 30 years, abrupt or severe hypertension, resistant hypertension, which is uncontrolled despite using up to 3 medications, paroxysmal symptoms like headache, sweating, palpitation, which can suggest pheochromocytoma, target organ damages present at diagnosis, and laboratory abnormalities like unexplained hypokalemia. Briefly, we'll look at the causes of secondary hypertension. We'll start with the renal causes, which include chronic kidney disease, polycystic kidney diseases, glomerulonephritis, chronic pyelonephritis, tubulointerstitial nephritis, and the bilateral renal artery stenosis. Now we'll look at the endocrine causes of hypertension. 1. Primary hyperaldosteronism, Cone syndrome. They cause sodium retention and potassium loss, which leads to hypertension and hypokalemia. Cushing syndrome, due to excess cortisol, which also has a mineralocorticoid activity. Pheochromocytoma, this is a catecholamine secreting tumor that causes episodic high blood pressure with palpitation, sweating, and headaches. Acromegaly, due to excessive growth hormone. Hyperthyroidism, hypothyroidism, both of them can affect vascular tone and cardiac output. Hyperparathyroidism, it can cause hypercalcemia, which may contribute to hypertension. Then congenital adrenal hyperplasia, this is a group of genetic disorders affecting steroid hormone synthesis. All these conditions should be considered when a patient presents with unexplained or resistant hypertension. Certain medications are also culprits of secondary hypertension. Oral contraceptive pills, especially estrogen-containing pills, non-steroidal anti-inflammatory drugs, corticosteroids, cyclosporine, decongestants like pseudoephedrine, licorice injection, cocaine, erythropoietin, and some certain antidepressants like venlafaxine. Other causes of secondary hypertension include coarctation of the aorta, sleep disorders like obstructive sleep apnea, or pregnancy-related hypertension, pregnancy-induced hypertension, preeclampsia, and eclampsia. Now we'll take a look at the clinical presentation. It's important for us to know that hypertension has no symptoms. So basically, most patients are asymptomatic. When symptoms occur, they are often as a result of target organ damages. Symptoms like headache, blurred vision, chest pain, palpitation, neurological symptoms of stroke, TIA, and so on. This arises as a result of target organ damages. Patients may present with hypertensive urgencies or emergencies. It's important to state that routine BP checks are very crucial. BP should be measured at least every 5 years in adults without known hypertension. Uncontrolled hypertension damages the vital organs over time. Let's start with the heart. Left ventricular hypertrophy, heart failure, coronary artery diseases like myocardial infarction, arrhythmias like atrial fibrillation due to structural heart changes. Now, the brain. Stroke, which could be ischemic or hemorrhagic, transient ischemic attacks, hypertensive encephalopathy, and vascular dementia due to chronic small vessel disease in the brain. Now we'll look at the kidneys. Hypertensive nephrosclerosis, eventually leading to chronic kidney disease, which could eventually progress to end-stage renal disease. The eyes, the retina in particular, hypertensive retinopathy, which can cause visual problems. Then the vascular system are also involved. Aortic dissection, aneurysm, peripheral artery diseases, and as-related atherosclerosis. This table summarizes the key target organ damage associated with hypertension. We look at the organs, the damages that happen, clinical features, as well as key investigations that can be done. Like we said, in the heart, left ventricular hypertrophy, heart failure, coronary artery diseases, arrhythmias. They could have several presentations, chest pain, dyspnea, palpitation, and so on. ECG, echocardiography, or cardiac biomarkers, as the case may be, could be useful investigations. Then the brain, stroke, which could be hemorrhagic or ischemic, TIAs, vascular dementia, and so on. The brain CT scan or MRI or even Doppler ultrasound scan could be very valuable. Then the kidneys, hypertensive nephrosclerosis, chronic kidney disease. Eyes, hypertensive retinopathy, which we are going to grade in the next slide. Endoscopy, optical coherence tomography, very important. Vascular system, aortic dissection and aneurysm, peripheral artery diseases. Present with claudication, diminished pulses, and limb ulcers. Vascular Doppler studies and CT angiography are also very important. We are going to look at the classification of hypertensive retinopathy. The Keith-Wagner-Baker classification is a useful system for grading hypertensive retinopathy based on fundoscopic findings. It is graded 1 to 4. Grade 1 is increased reflectiveness, increased tortuosity, and arteriolar thickening, often referred to as silver wiring or copper wiring. Grade 2 is grade 1 plus arteriovenous nipping, which is a constriction of veins at arteriovenous crossings. Grade 3 is grade 2 plus signs of retina ischemia, such as flame-shaped hemorrhages, blood hemorrhages, cortical spots, and hard exudates. Grade 4 is grade 3 plus papilledema, which is swelling of the optic disc, and this indicates malignant hypertension. Endoscopy is a vital tool in evaluating hypertensive patients and should be part of the routine examination, especially when blood pressure is severely elevated. Here we have some of the fundoscopic changes in hypertensive retinopathy. Grade 1, we have silver wiring, where the retinal arteries appear shining and metallic. Grade 2 is the arteriovenous nipping as indicated by the white arrow, where an arteriole compresses on the venule at crossing points. This image shows fundoscopic changes of grade 4 retinopathy, where we have hemorrhages, cortical spots, and papilledema. Now we'll look at hypertensive crisis. The hypertensive crisis is a sudden and severe elevation in blood pressure, typically systolic 180 and above, and diastolic 120 millimeters of mercury and above. It is a medical emergency and comes in different forms. We have hypertensive urgency, hypertensive emergency, accelerated hypertension, and malignant hypertension. Distinguishing between these is critical because the urgency and the method of treatment differs drastically. We are now going to break each one down in the coming slides. Let us start with hypertensive urgency. Here, the blood pressure is severely elevated, usually above 180 over 120 millimeters of mercury, but there is no evidence of target organ damage. The patients are often asymptomatic or they will have mild symptoms. Key points to note in management is that hypertensive urgency is not immediately life-threatening. The goal is to lower the blood pressure gradually over hours to days, not minutes. Here we use oral antihypertensive and not intravenous drugs. Close monitoring and follow-up is essential to prevent progression to an emergency. Now, hypertensive emergency. This is a more serious situation. Here the BP is similarly elevated, but the key difference is that there is acute target organ damage. This could be stroke or encephalopathy, acute heart failure, myocardial infarction, aortic dissection, acute kidney injury, or even papilledema with visual changes. These patients are critically ill and need urgent care in the intensive care unit. Treatment involves parenteral antihypertensive to reduce pressure quickly. The goal is to lower mean arterial pressure by about 20 to 25% in the first hour, and then more gradually over 24 to 48 hours. Accelerated hypertension. This is defined as a rapid and severe rise in blood pressure with signs of acute vascular damage, particularly in the retina. Features include retinal hemorrhages and exudates seen on fundoscopy, but no papilledema. This is the key distinction from malignant hypertension. It's dangerous and can rapidly progress if not treated. Management includes urgent but controlled BP reduction. Depending on the severity, we may use oral or parenteral antihypertensive. Close monitoring is crucial to prevent progression to full-blown malignant hypertension. Now we come to the most severe form, malignant hypertension. It is a medical emergency and is defined as severe blood pressure elevation, typically above 180 over 120 millimeters of mercury, with acute target organ damage and papilledema. Other features may include retinal hemorrhages and exudates and other visual changes. The condition has a high risk of death without immediate intervention. Management includes admission to ICU, commencement of parenteral antihypertensive. Immediate controlled BP lowering is very important to preserve organ perfusion. Delaying treatment in malignant hypertension can result in permanent damage or death. This is a table outlining the various hypertensive emergencies per organ system. The brain, hypertensive encephalopathy, acute ischemic stroke, intracerebral hemorrhage. The heart, myocardial infarction, acute left ventricular failure, blood vessels, aortic dissection, sympathetic crisis. In the kidneys, acute kidney injury. The eyes, acute hypertensive retinopathy. Pregnancy-related eclampsia and severe pre-eclampsia. Let us take a look at blood pressure measurements. The patient should rest quietly for 5 minutes before blood pressure measurement. Avoid caffeine, exercise, and smoking for at least 30 minutes before measurement. Sit with back supported, feet flat, arm at the heart level. Ensure we use validated calibrated sphygmomanometer using of the correct cuff size, and the cuff bladder should cover about 80% of the arm circumference. Now let us go over the actual measurement technique. First, place the cuff about 2 to 3 centimeters above the elbow crease. Inflate the cuff to about 20 to 30 millimeters above the point where the pulse disappears. Then slowly deflate the cuff at a rate of about 2 millimeters mercury per second. While listening with a stethoscope over the brachial artery, identify the first cough sound. This is the systolic blood pressure. The disappearance of the cough sound is the diastolic blood pressure. Here are some key measurement tips to ensure consistency. You record the blood pressure to the nearest 2 millimeters of mercury. Always take at least 2 readings, 1 to 2 minutes apart. If the readings differ by more than 5 millimeters of mercury, take additional readings and use the average. Measure the blood pressure in both arms during the initial visit and use the arm with the highest reading for future checks. If there is a suspicion of abnormal BP patterns, consider home or ambulatory blood pressure monitoring. Accuracy at this stage can make all the difference in the diagnosis and follow-up. Briefly on ambulatory blood pressure monitoring. When do we use it? If we suspect white coat hypertension or maxed hypertension. It is used to confirm diagnosis when clinic blood pressure readings are at borderline. The ambulatory blood pressure monitoring is a 24-hour blood pressure recording during daily activities and sleep. It is the gold standard for diagnosing true hypertension. The home blood pressure monitoring. In this method, patients check their blood pressure at home using validated digital devices. Advantages include it helps to detect BP variability. It provides better representation of the patient's true blood pressure. It's also a stronger predictor of cardiovascular outcome compared to office readings. Home blood pressure monitoring empowers patients to take charge of their condition, promotes adherence, and improves follow-up. It is an excellent tool for ongoing management. Diagnosis and evaluation. When evaluating a patient with hypertension, history taking is critical. You begin with the duration and onset of hypertension. When was it first noticed? Was it diagnosed during a routine checkup or due to symptoms? Ask about previous treatments. Were they ever prescribed antihypertensives? Are they compliant? Inquire about associated symptoms like headache, dizziness, blurred vision, chest pain, palpitation, breathlessness, nocturia. These symptoms could indicate target organ involvement or even a hypertensive crisis. Always look for clues suggesting secondary hypertension. Ask specific questions like weight gain, facial swelling, irregular periods. This may point to Cushing's syndrome. Muscle weakness, leg cramps, frequent urination could suggest Cushing's syndrome, also known as primary hyperaldosteronism. Episodes of palpitation, sweating, pounding headache. These are classic signs of pheochromocytoma. Flank pain, blood in urine may indicate renal disease. Next, we'll review medications and substance use. Ask about non-steroidal anti-inflammatory drugs, corticosteroid, contraceptive use of decongestant or any herbal products. Inquire about alcohol intake, smoking habits, and recreational drug use, especially cocaine. Then explore lifestyle factors, dietary habits, especially salt intake, physical activity, weight gain or obesity. And finally, assess family history. Are there any cases of hypertension, stroke, heart disease, or kidney disease in close relatives? All of these help in risk stratification and planning management. The final part of the history taking will involve asking questions to screen for target organ damage. Ask the patients if they have experienced chest pain or shortness of breath. This may suggest heart failure, coronary artery disease. Ask for blood in urine or frothy urine. These are early signs of kidney involvement. Visual disturbances may indicate hypertensive retinopathy. Cognitive issues or sudden confusion could be a sign of cerebrovascular disease or hypertensive encephalopathy. The physical exam plays a vital role in evaluating hypertension. First, look for signs pointing to secondary hypertension. 1. Radiofemoral delay and or weak femoral pulses. This may suggest coarctation of the aorta, especially in younger patients. Palpable or enlarged kidneys could indicate polycystic kidney disease. Abdominal brow, especially over the flanks or epigastrium, may suggest renal artery stenosis. Cushingoid fasciitis, such as moon face, central obesity, striae, and proximal muscle weakness may indicate Cushing's syndrome. It is important to be systematic and thorough. These findings may be subtle, but provide critical diagnostic clues. Next, we assess for evidence of target organ damage. We'll start with the heart. You look for apical heave, which suggests left ventricular hypertrophy. A displaced apex beat may indicate enlarged heart. Systolic murmurs, especially of aortic regurgitation, can also occur. The vascular system. Check for diminished peripheral pulses or radiofemoral delay. Palpate for aortic aneurysms. The eyes. Perform fundoscopy to detect arteriovenous nipping, cottonwool spots, or papilledema. In the abdomen, feel for renal enlargement or masses. Listen for renal brew. In the brain, look for any focal neurological deficits, which may suggest stroke or transient ischemic attack. These signs help you to determine the severity of hypertension and guide urgent decisions. Also use physical exam to identify cardiovascular risk factors, like central obesity by checking the waist circumference. You look for signs of hyperlipidemia such as xanthomas on tendons, xanthelasma around the eyes. Also do a general cardiovascular assessment. You listen for murmurs, gallops, carotid brew. Examine the lower limbs for signs of peripheral arterial disease such as absent pulses, skin changes, ulcers, or gangrene. Now let us talk about the baseline tests you should order for any patient newly diagnosed with hypertension. These tests are mandatory and help assess for complications and comorbidities. 1. Urinalysis. You look for proteinuria or hematuria, which suggests kidney involvement. Serum electrolytes, urea, and creatinine helps to evaluate renal function. You can also check for hypokalemia, which could indicate hyperaldosteronism. Fasting plasma glucose or glycated hemoglobin helps to screen for diabetes mellitus, a common comorbidity. Lipid profile is also very important. You measure the total cholesterol and high-density lipoprotein cholesterol to estimate atherosclerotic cardiovascular disease risk estimation. Then, electrocardiogram. This detects left ventricular hypertrophy, ischemic changes, or arrhythmias. These tests form the foundation for risk assessment and treatment planning. If secondary hypertension is suspected or organ damage is evident, you move to some other investigations. We'll start with imaging studies. Chest X-ray. You look for cardiomegaly, signs of heart failure, or rib notching, which may suggest coarctation of the aorta. Renal ultrasound scan. This is to check for polycystic kidney disease or small echogenic kidneys seen in chronic kidney disease. Echocardiography. This provides a more detailed view of the heart to detect left ventricular hypertrophy, diastolic dysfunction, and valvular disease. This test provides structural insights and confirms suspicion raised during history and physical examination. Then we look at hormonal investigations that can be done. Plasma aldosterone renin ratio. This helps to screen for primary hyperaldosteronism. 24-hour urinary cortisol or overnight dexamethasone suppression test. This helps to assess for Cushing syndrome. Plasma metanephrines or 24-hour urinary metanephrines. This is used to detect for pheochromocytoma. Thyroid function tests. This helps to rule out hyperthyroidism or hypothyroidism, both of which can affect the blood pressure regulation. Use this test selectively based on clinical suspicion. Next, consider advanced diagnostics when indicated. Renal artery Doppler ultrasound scan or CT angiography to evaluate for renal artery stenosis, especially in young patients or those with sudden onset or resistant hypertension. Sleep study polysomnography indicated when you suspect obstructive sleep apnea, especially in obese patients who snore or have daytime somnolence. These help confirm less obvious secondary causes of hypertension, and allow you to address them quickly. Briefly on cardiovascular risk assessment, the QRICS. Management of hypertension should not focus on blood pressure alone. Consider overall cardiovascular risk. The QRICS tool helps to estimate a patient's 10-year risk of having a heart attack or stroke. It considers factors like the age, the sex, the ethnicity, smoking status, blood pressure readings,
cholesterol levels, presence of diabetes,
body mass index, and family history. Other conditions like chronic kidney disease or atrial fibrillation are also factors to be considered. If the QRICS score is 10% or more, guidelines recommend initiating statin therapy such as atorvastatin. This approach ensures treatment is comprehensive and risk-based. Let us wrap up with some essential take-home messages. Hypertension is often silent but deadly. Accurate diagnosis requires multiple blood pressure readings, ideally confirmed with ambulatory or home blood pressure monitoring. Use updated guidelines to guide treatment decisions. Always screen for secondary causes when the presentation is atypical or resistant. Identify and evaluate target organ damage early. It affects prognosis and treatment urgency. Use tools like QRISK to tailor management based on cardiovascular risk, not just blood pressure alone. Do not underestimate the power of lifestyle changes like exercise, diet, and weight control. They are as important as medication. These principles will help you manage hypertension more effectively and reduce long-term complications. Thank you for your attention. This concludes part 1 of our lecture on hypertension, covering classification, causes, and clinical evaluation. In part 2, we will discuss treatment options and follow-up strategies and management of special situations. Until then, stay curious, stay informed, and keep saving lives. Do not forget to subscribe to our channel, like and share this video. Click on the notification bell to stay updated when new videos are uploaded. Thank you and see you in the next video.